And welcome to session B1, Quality Drives Out Cost. I hope everyone had a good lunch and you're ready for some interesting presentations this afternoon. Today we have three speakers, Andrew Stripp, Ann McGee, and Hugh Rogers. And the way we're going to organize this session is that each presenter will present for about 15-20 minutes, and then we will take questions and answers from that presenter, and at the end we'll have a short wrap-up conversation. Given the size of the room, I would ask that if you have a question, please step up to a microphone, and we'll just rotate through the microphones as we go. So with that, I'd like to introduce the first speaker. Andrew Stripp is the Deputy CEO and COO of Alfred Health from Melbourne, Australia. He's trained as a clinical psychologist and has a business background and has been working in his current position for around 7 years at Alfred Health. So without further ado, I'll invite Andrew Stripp.
Thank you. I'm having trouble walking upstairs at the moment. I thought I would help my jet lag by running the Paris Marathon on Sunday. I'm not sure about that. I think there must be a simpler way of dealing with jet lag. Let me find my way here. So thank you. What I'm going to talk to you about today is really a fairly simple approach, but I hope just provides you with some suggestions or prompts as to how you can deal with really about how we transition or translate ideas that we're constantly dealing with into action with a tangible result. As I said, it's relatively simple, but I hope it's thought-provoking. So a little bit about where I'm from, Alfred Health, about 3 hospitals, different in nature, a large tertiary quaternary hospital being the Alfred, Caulfield and Sandringham hospitals, a subacute hospital and a small community hospital, located in Melbourne, in Australia, down the bottom tip. We have a budget of around $900 million per annum, and there's some of the numbers that give you a bit of a sense of what we do. We're a little unusual in that more than half of our patients come from outside of our primary area, and that's largely because we're a designated statewide trauma service, something that recently Royal London has been pursuing in terms of a model of approach in terms of management of trauma care in the UK. And also we're a large transplant centre for a good part of Australia, plus a number of other specific and designated services. We think that we're doing pretty well in terms of the sorts of metrics that we monitor, and just as a flavour, you know, our financial and access performance is travelling well, and we're meeting all the necessary indicators that we want to achieve. We've got good patient safety outcomes, and we've been putting a lot of work into our hand hygiene rates and central line infections, etc., etc. Very similar to what I'm sure many of you are also doing. And I think naturally within each of our medical units and our wards we have a good level of adoption of best practice initiatives. And as you know, there is lots of material and information around that we can draw on to help us with some of that work. And here's a couple, I suppose, that I've just put up that we've drawn on: the basket of day case procedures or variations in healthcare, and we've heard about some of the others already this morning. And just across the ocean from us in New Zealand, Jonathan Gray, who's, I know, at the conference doing some work with his team around unwanted variation and a similar sort of map to what we heard just a little while ago. But of course, I don't know about you, but I certainly find that as I wandered the corridors of our hospital, we come across all sorts of other little suggestions, and whether it's the nature of medical politics or the nature of just general conversation, they happen to often come up in an informal way. And you know, things like why do we use IV paracetamol, or somebody else in the coffee queue will tell me that those ICU guys overuse routine chest x-rays. Or somebody else will tell me that the emergency physicians put too many chest tubes in. And usually after this long conversation, someone sort of says as they walk away from me, someone should do something about this. And I suppose for a while I carried this around thinking, yes, someone probably should do something about it, and didn't really give it too much thought, although I'd maybe have the odd conversation with individuals. But often felt that we didn't really have a clear way of progressing it. We're quite good at investment decisions within our hospital and our health service, so making decisions around an evaluation about whether we'll adopt new practice. Again, I'm sure similar to much of what you do around equipment committees and drugs and therapeutic committees, you know, whether we'll adopt a new drug or a high-cost drug and whether the evidence is there. Innovation review committee, so whether a new procedure will be adopted, whether the new approach in neurosurgery or in general surgery or colorectal surgery is something that we should bring into the hospital. Considerable amount of time about whether we should do urology robots. We're not, for example. But also not so clear about divestment decisions. As I said, pretty good at a local level, but with some of those ones that I just referred to, felt that it probably wasn't as strong as we'd like it to be. So we set up a clinical practice review committee. You could call it any number of things. I think at one stage we called it an evidence-based review committee, which really sole purpose was to bring together a number of our senior medical leaders across the hospital, typically senior academic staff, with a chairperson drawn from that committee with a set of skills that was about facilitating and encouraging and not letting debate stop, but really focusing on encouraging a level of what I would call simply creative tension, with a view that from that creative tension we'll get a better product. And at the first meeting, I simply tabled a long list of my coffee and corridor conversation items for discussion. And in that discussion, we went through a whole range of areas and we ended up with I suppose, an action sheet, which I'll just go back. We track and we monitor, and this is the range of things that we've been looking at. ICU chest x-rays, compression stockings, and a use in particular when thrombolysis is present, chest tubes, IVC filters, etc. You know, you'll have these overheads, of course, and my colleague who works with me, who's a practicing clinician, works as an executive officer, who's also in the audience, will be more than happy to talk to you about some of the detail, I hope. But I suppose setting up a project management framework and a capacity to track and monitor. But really, I suppose the key part of that initial discussion was, is there some reason or benefit to looking at this a bit further? Is there sort of a case to answer, or is it something that we can do some more work on, or is it something we're going to drop off? And just to give you a sense of how we've been travelling, we did some work around routine chest x-rays. Just around the same time, there was some very good literature published around the move, around quality impact of moving from routine daily chest x-rays on ICU patients to PRN-XAs, and we reduced it by 30% with the adoption of that practice. And a redistribution and cost avoidance associated with the radiography staff that were doing that work. IV paracetamol, we've almost eliminated from the hospital, and again, practice change associated with that and a direct cost saving. I suppose one of the key parts of this is that what we've done is we've really said ideas can come from anywhere, and they'll be picked up and understood by Damien, who I was referring to a moment ago, and it's either not for further consideration when it's tabled at the group. It might be we need to do a little bit more work to understand it a bit better. We might actually formulate and initiate a specific project to understand it and start to develop it and make a decision around how we'll either divest or change our practice. Or we might commission our own study. We might actually get our university colleagues to develop up a more formal or informal study to actually come to an understanding about what we want to do. A classic example for us is nitric oxide. We've reduced that use and contained the cost, but we've not been really able to find much evidence in relation to its use in relation to transplantation. So it's something that we're thinking about looking at ourselves, given our sort of high volume of transplantation work. We embedded the committee within our clinical governance structures, so through our Chief Medical Officer and our Health Service Executive. And I sit on the committee not really to make any useful contribution to the content of discussion. I'm not medically trained, but my real focus is on process management and making sure that I can sponsor and progress the discussions. As you can imagine, in these sorts of things, sailing's not always smooth. Recently we decided that we'd venture into the surgical area and ask, are we unnecessarily intervening, or we perhaps could we wait a bit longer, or are we doing procedures for patients that perhaps could otherwise be avoided given their stage of illness. And the immediate response from a number of the surgeons when this was tabled by a head of surgery was that they should make a referral to their college to get legal advice, to issue me with a note to tell me that I had slandered and committed libel in relation to their practice. We spent some time talking that through, and the letters and the like didn't appear, and I don't think there was ever really an attention, but I suppose that what we've found is that consistently in this process is that initial reaction, particularly early on, of people getting a sense that we're questioning or challenging their professional integrity and professional practice with comments like, we're on top of what we do in our unit. There's a national guideline or a statewide guideline. How on earth could we change it? And we've certainly hit that in relation to the stockings, the compression stockings. Or sometimes someone's just raised that issue. They're running their own agenda. They just don't like what we're doing. What we're doing is fine. And I suppose from my point of view, and part of the rationale of the committee is that we've made sure that irrespective of what sort of reaction we get, there is a sense of keeping people involved and not a loss of control, but also a commitment to seeing those issues through. And in some ways, some might say that the stronger the reaction, perhaps the more resolved we are to have a little bit of a look. I was reflecting on some of my slides from an earlier presentation I gave a while ago, and Jonathan Gray had this nice sort of little set that I thought I'd share with you, if you haven't seen it already, in relation to some of those initial reactions of people, which is sort of that dismissing of data through to the data's right but not our problem, etc. Dollars redeployed, saved or avoided, which is part of the reason that I'm talking to you today, and what we're all trying to do is how do we improve quality but reduce cost. As I said, reduction in spend on IV paracetamol. The introduction of that had happened in a very natural way within the hospital. There were good reasons to it, but in terms of practice, or behaviour perhaps I should say, but no clinical benefit. Nitric oxide, ICU chest x-rays, significant effort we've made in relation to the use of vacuum dressings, particularly around plastic surgery and outside of plastic surgery, and an issue that, given our high volume of trauma work, has been important. And many of the others that I referred to earlier in my slide. So some of the things that I think we need to think about when we're doing this, and we constantly reflect back on, clearly the involvement of senior medical staff or consultant staff is important. It's not just involvement or ownership. Sometimes I'm asked, whether it be around this sort of work or others, do we really need to have the doctors at the table? I sometimes think that people want me to say, no, you can do all of this without the medical staff. But we all know that that's simply not true. And it is about clinical practice, and it is about clinical leadership. I think one of the key aspects of any of this sort of improvement work or change work is it's very easy to come up with ideas or concepts. It's very different to then translate that or operationalise that and achieve sustainable change. And I think often it's either through the direct involvement of those senior medical staff and obviously senior nursing staff where that's relevant that can be achieved. Acceptance of the referral is not an implication of wrongdoing. Constant, as I mentioned a little bit earlier, is that sense of managing a culture that raising an issue or having a discussion isn't wrongdoing, but simply a matter of good process. And in many ways, I think we would argue that at a tertiary hospital and a university hospital, we're obligated to review and consider and reconsider our practice. Senior executive sponsorship, obviously important. I think it's fair to say that some of the issues and walls that we hit, whether it be that sort of knee-jerk reaction or others, just requires either myself or one of my senior colleagues to sit down with the people involved and reassure them about the process and enable it to continue to progress. Can't understate the role of the chairperson. As I said, that capacity to create and have that creative tension, very important. And open process. So the process really being to anyone. We've had a number of people who've simply said that they wanted to come along and meet with us or sit in on the committee, which of course we're very happy to do. And similarly, the resilience in dealing with some of those issues, it can be tough and difficult to progress. So just if you weren't sure where Melbourne is, I went to I think an NHS meeting a couple of years ago and sat in on a trauma meeting to hear about what they were thinking about, and the presenter who was doing the review around trauma services for the UK said he'd been looking at the Alfred Hospital and its model, and if people didn't know where it was a little colonial spot in the southern hemisphere. We had a good laugh about it when I introduced myself, but that's where we are, and that's a nice aerial shot. Some contacts or further information, that's my email, and Damien, who's down the front, would be more than happy to help you if you've got any questions. Thank you.
So now we can take some questions if anyone wants to stand at the microphone, if you'd be so kind.
I'm Peter Barner, Central Denmark Reading. I may have missed out something, but where do your ideas, your themes that you take up in this committee, where do they stem from? Do they come from the clinic, from clinical management? Do they come from outside, for instance, national guidelines? Or do you, as an executive or a board, invent them yourselves? Is it top-down, or is there a bottom-up movement as well?
It's very much bottom-up. It's very much, the initiation of it was very much a collection of people's ideas from around the hospital and an encouragement to do that. We've just recently written to every member of the senior medical staff again to encourage them to raise issues or themes with us to investigate. We've said that we've got the capacity and the resources to do that. Having said that, we'll take ideas and concepts from anywhere really, but the core of it is that sort of integration with the broader clinical workforce who, as we know, are faced with and confronted with and frustrated with waste and issues not uncommonly.
Any other questions? I'm afraid people are being shy about walking up to the microphones. Maybe I could ask you just one. I'm going to pose just one question related to cost. Do you have ideas that come through that are specifically ideas for cost reduction, or have the cost reductions that you brought up today been a side effect of improving the care?
Yeah, I think it's mixed. I mean, the very simple one about IV paracetamol was just a cost and waste. It was raised by our head of anaesthesia. And the areas were in anaesthesia, interestingly, in our ICU particularly, and in one of our wards. There has, without any doubt, early on quite a tension in terms of having a conversation in the group where quality and cost was discussed in the same breath. And I think a bit of a struggle by the committee about whether it was specifically driven by cost or quality. And the sense was that, and the agreement was that it was very much quality focused. We had other ways of dealing with cost-driven exercises, but it would be primarily quality and safety and unnecessary intervention. But that, of course, if there was a cost issue that had a direct patient safety or clinical impact, then the group could also consider it.
Thank you.
I'd like to ask a question. Presumably the group must have generated some ideas they wanted to implement that actually had a cost impact. How did you handle that?
Yeah. So that's certainly been the case, and we've, in relation to, I think, Damien, nitric oxide in the ICU, we switched the nature of the type of pharmacological intervention, which had a different cost base. Which, we were open to do that. We've said that it doesn't necessarily have to reduce cost in of itself. If it's creating efficiency or, at the end of the day, a better patient experience, then we would do that. Well, I think, at the end of the day, one of the benefits for the committee of, someone in my role sitting there and being able to make, quick decisions in relation to that.
Any other further questions that have come up? No. Great. Thank you, Andrew. Our next speaker is Anne McGee. She's from the Leeds Community Healthcare, part of the NHS Trust, the biggest provider of community services in that area. And Anne is the service improvement lead, and she'll speak more about the project that they're doing. Thank you.
Thanks, Kim. Hi, everybody. I don't usually present at international conferences, so this is a real thrill and privilege for me. And I've been struck already, I think, by the thing that connects us here. I've been speaking to people from South Africa, from Ireland already, and have been struck by the fact that we're all, I think, motivated by the desire to improve quality in the face of the challenges that are around universally, particularly around increasing demand and reducing costs. And that's certainly been our experience in Leeds. So over the next 15 minutes or so, I'd like to share with you our story and hopefully can connect with some of the issues that are happening in your situations and environments too. Okay, a little bit about Leeds. For those of you that don't know, it's in the north of England, in the county of Yorkshire. Fantastic city. I'm a little biased because it's my hometown, and it's great to live and work in your hometown, as I haven't always done that, so I really appreciate that now. Historically, an industrial-based city, but has been very successful in transforming itself to a broad-based commercial centre, particularly in the last 20 to 30 years. And has been so successful that it is now outside of London, in terms of England alone. Outside of London, it is the most important financial, business and legal centre. But not everybody shares in that success, and there are some areas of real deprivation in our city where the inequalities in health and society generally, I guess, are still unacceptable. A little bit about the populations that we serve. Diverse and dynamic, as hopefully the slide indicates. We've got about 770,000 population, growing population at both ends of the spectrum, actually. We've got an increase in young people and families, and in line with many societies and communities, a growing elderly population, particularly the over 80s. And so that presents particular challenges for us. In researching this, I was struck by a quote that said, Leeds is a magnet for young people, families and migrants. And maybe success breeds success and brings that energy and diversity to our community. And my organisation provides community-based services. We work in the community in order to deliver healthcare. And that, because we work in the community, I think that gives us a different dimension often to people working in a hospital setting. So we are the largest provider of community services in Leeds, part of the NHS. We employ 2,500 staff. We have a turnover of about £140 million per year. And our mission is to provide the best possible care in every community. We deliver our care in a huge variety of settings. We have people working in schools, in health centres. We have 3 inpatient facilities, so some hospital-type environments, and prisons as well. We provide healthcare to the 3 prisons in and around the city. And Most interestingly, I think we provide care in people's own homes. And again, that adds a different dimension. We are a guest in people's lives. I'm not going to talk too much about the context because everybody knows what that context is. The financial challenges and the demands for services are well established. In the NHS as well, we're dealing with unprecedented system and structural reform through the recent Health and Social Care Act, and that provides its own challenges. So, about 3 years ago, it became apparent that the financial context was such that we were going to have to think about things in a different way. We needed, if we were committed to our mission and dedicated to improving the services that we provide, we needed to think about that because it was going to be difficult to continue to do that in the economic climate and the financial climate that we faced. And we developed what we call the Leeds Approach, and this is what specifically I'm going to share with you today, a systematic organisational improvement programme to enable us to deliver our mission. Its objectives were to improve or maintain quality, and as a byproduct of that, and alongside that, to increase productivity. It's a fact, we have to do more with less in our organisation. But we wanted to establish a culture of improvement and to build the organisation's improvement capacity and capability. We want to encourage innovation and we have to reduce spending. In 2009, a small delegation of us went across to Jönköping in Sweden and were completely inspired by that experience. I know people in the audience today hopefully will also have benefited from that. But the clinical microsystems model, which is central to the Jönköping experience, really resonated with us. And for people who don't know that, and I'm sorry the slide might not explain that too clearly, but fundamentally it's about the relationship between the patient and the family surrounded by the team that deliver care to them. And using that concept as the building block for your organisation. It's the stuff that Maureen was talking about in her opening keynote address this morning in terms of that partnership and relationship with the community. And the work that has emanated from this concept really felt achievable for us in Leeds. And the second aspect of learning that we took on board was the concept of kulturen from Jönköping. So this is about creating a culture of improvement within an organisation. And the fact that in order to do that, you need to equip people who work within the organisation with the improvement knowledge and skills to make the improvements that they want to see and to bring people together in order to share and learn from one another. So we were interested in exploring that. So taking that thinking and taking the context that we were facing, we came back and thought, let's build an organisational model based on microsystems principles, where we can empower and equip and engage our frontline teams to be the driving force within our organisation. And the slides there are examples of all the different teams that we're currently working with. The model then, how do we do this? What do we do? And this model has evolved over time in true PDSA style. We tried it and amended it, and I think this feels like kind of the best way currently to approach things, but I'm sure we'll continue to refine and develop all the time. Start with a diagnostic at team level. So we're looking at a frontline team, a frontline microsystem, if you like. What are the issues within that team and service? And that diagnostic process involves patients, the staff, what are the issues from commissioners, what's the information telling us about what the improvement agenda needs to be. And that really sets the framework. I was struck by the discussion in the last session I attended, Helen Bevan's session, where she was talking about an asset-based approach to improvement. And I think we need to build that into our diagnostic. What's already working well, and what can we do more of that's working? As a result of the diagnostic, we select priorities to work on and use the ease impact matrix. So what's achievable and what will deliver a significant impact. And then it's about what tools and frameworks and facilitation resource are needed to enable us to make the progress that we want to see. And finally, the microsystems, the teams, the frontline teams, lead that work. This is their agenda. This is not a top-down managerial instruction. Okay, a little bit about the frameworks. We've worked closely with the NHS Institute for Improvement and Innovation, and my colleague, I think might be in the audience, Sean Manning, particularly, has been instrumental in helping us to develop our approach. And one of the key frameworks that we've used is the Productive series, which is a modular-based approach that enables teams to look at the fundamentals of what they do and improve the way they do them. And productive community services, which has particular relevance in our organisation, was just being launched at the time that we were developing our approach. So the synergy there was brilliant. So we use the productives extensively in our organisation. Productive community services, the productive leader, the productive ward for the inpatient environments. And I know Hugh's going to talk a little bit more about this situation in an operating theatre context in his presentation. But the frameworks have enabled us to move forward significantly. So where are we now? I should have said that we have 65 services covering both adults and children's services in our organisation. And currently about 2/3 of our services are engaged in the process. Over the last 2 years, because this is a 3-year kind of programme in order to engage everybody systematically, and we're 2 years into that, in that last 2 years, massive increased application in the improvement knowledge and application in our organisation. Undoubtedly, it's great to kind of see that in action. And a fantastic byproduct is the fact that unexpected leaders have emerged through this work. So people that wouldn't normally lead improvement work have, if they get this, then they can run with it. And the culture is beginning to happen whereby it doesn't matter what your level is in the organisation, you can put your hand up and lead the piece of work in your environment and take that forward. And that's been one of the best things, I think, about it. In terms of culture of improvement, are we achieving what we want to achieve? Well, we're early days. We're only 2 years into this, and I think establishing a culture takes longer than that. But we are definitely beginning to see the signs. And another thing that we've adopted from Sweden is this catchphrase, which is in common parlance in our organisation, which everyone at LCH has got 2 roles: to do your job and to improve your job, to improve the way your job is done. And we are getting to a point, I think, where that feels real. That has implications because that's about headspace and giving people the time to think about what they do, which is not always easy in a delivery context. Okay, a little bit, I'm going to skip this one, a little bit about the improvement stories from the frontline teams, because this is the interesting stuff. And I'll focus on this service, which is our Musculoskeletal and Rehabilitation service. One of our big services, their annual budget is about £5.5 million, 135 staff, whole-time equivalents. There are more bodies because people work part-time. And in the last financial year, so 2011-12, they had a savings target to achieve of £257,000, which was about 4.7% of their budget, and they achieved that. They commenced the Leeds Approach in August last year, and their priority, which was identified through a big engagement workshop around what should we focus on, was about improving access to the service, so delivering a 2-week waiting time and focusing on maximising their capacity in order to enable them to do that. Some phenomenal work by this service, completely redesigned their clinic system, cleared their backlog of waiting patients by putting on some extra sessions, some work to standardise treatment times and the number of patients seen in clinics, because there was significant variation, reducing did not attend appointments, and identifying and eliminating bottlenecks, which in their case was access to MRIs. I think, though, the thing that's been particularly successful about this piece of work is how it has been led and managed by the people that work in that service. And the manager of this service has played very much a back seat in how this has happened. She has enabled the team and empowered the team to deliver the improvements that collectively they'd identified they wanted to see. And I've just got a little clip of some members of that service talking about their experience.
What was going on there? Yeah. You kind of look back and say, actually, that was quite inefficient. Yeah. Now, and actually now these are better ways of working.
Yeah, be able to suggest things, because you might have loads of really good ideas, and it's just that you're not a manager, so you don't get the chance to put those ideas into practice. Whereas actually, with this sort of process, hopefully everybody has a bit of a chance, even if you're not on one of the groups, you get a chance to talk to the people from your area that are.
It has been that involvement of the staff really, at every single level, that's been very, very good. And I think it has, I feel really, that it's meant that people have had a bit more ownership of the problem, in that it's not just a management problem anymore, it's actually everyone's problem, and actually if we manage it together, then we can actually move things forwards.
So we've all got shared responsibility, it's not just management responsibility, we are in control of our own destiny to a certain extent.
Okay. I think, just to reiterate, I think what I was trying to say about that service, they have delivered their financial target, not necessarily through this work. They've delivered their £250,000 through various measures, not filling vacancies and so on. But I think what they have achieved is being able to improve the quality at the same time as that resource has been taken out. And they've done that in a way that engages the staff and enables the staff to drive that forward. Which feels like the right thing to do. Okay, have I got time to do another story, do you think? Okay, a second story then, complex and palliative continuing care service, that's quite a mouthful. A much smaller service, largely of unqualified nursing staff who support professional nursing staff to deliver care to people who are dying, people they're at the end of life. And they commenced the Leeds Approach in 2011 as well. Their priorities included improving the quality and the patient experience, and they had a particular example of needing to have an emergency stock of continence products, actually. When people are discharged from hospital, often they were done so in a situation where they were left without the products that they needed. And so they've redesigned things and enabled their team to have access to this supply, and that's been of direct benefit to the patients. They've also improved their efficiency through one of the productive tools, which is patient status at a glance. So they've reduced their handover time through the use of whiteboards. And that's reduced time and frustration in the process for allocating work. Again, a little clip here.
I think the whiteboard, really, one of the achievements there is reducing handovers. We don't tend to have a handover every day now, which we used to do.
We don't.
Because obviously all the information, a district nurse might ring in and say this person's gone on the LCP, whereas before we'd feed that over in handover at lunchtime. Now it's written on the board, so as you're coming in and looking at your afternoon visits, you can see where everybody is. You get more patient contact, really, don't you? Because we haven't got that half an hour wasted now from 2 till, well, not wasted, but 2 till past doing a handover. It's just all there on the board and you can, you know, just get out there.
I think it's a lot better.
The whiteboard's fab.
Well, what about achievement?
Fab.
Okay. Our overall achievements then. In the last 2 years, Leeds Community Healthcare has delivered an increase in activity of 9%. We have reduced expenditure by 8%. That's about £9 million. Undoubtedly, we are a more productive organisation. But what's more important is the fact that by doing that, or at the same time as doing that, we've been able to maintain our patient satisfaction and experience levels. We measure this monthly through a tool, and it's consistently around the 95% level, which we think is phenomenally high. That's not to say that we don't think there are areas for improvement. There definitely are. But we can also measure our quality standards and, again, have maintained and improved those. We have a quality framework tool that measures those, our Care Quality Commission standards, and all the Leeds Approach improvement stories, such as the ones that you've heard, demonstrate to us that quality work is continuing to happen despite the fact that we are having to reduce resources and increase activity. I'm not going to stand here and say that everything is fantastic in Leeds Community Healthcare. There are still some issues. I looked at our staff sickness data just before I came out, and there is a slight upward trend in that. And staff in some services are having to work very hard. And we haven't quite got our recruitment right in terms of filling vacancies, and that's putting some pressures in our system. And that's what we want to address. But we've made some good progress, and this is a continuing journey. So our learning, engagement and empowerment of our staff are critical to delivering our agenda. And it's about not telling people what they need to do, but empowering and enabling them to do what they feel they want to do, based on an analysis of what the information is telling us, the data, the feedback and so on is telling us that the priorities are. And I think we need to develop that further from the learning today, really, the bringing our community in as real partners for that. Second learning point, improvement at LCH is at the centre of our strategic agenda around quality and productivity. It's not something that's done as a sideline in a corner. And I think if you're going to make transformational change, it has to be a central agenda. I think there are resources required to support improvement. People, tools, skills. What I haven't put there actually is time. And our experience indicates that if we don't have that, the journey may stutter and stall. And then it's all about leadership and leadership at all levels. So from our chief executive who espouses this, but right through the middle management levels and down to frontline staff who want to take the initiative. And that, where next? Okay, a whole agenda that we want to continue with. So we want to get the rest of our services on board and should do that by the end of this year. Want to keep people engaged and connected and really want to spend a bit more time thinking about how we do that, using some of the social movement thinking around that. Pathways of care. So actually, quite a lot of our work has been internally focused. Our next step is around the integration with other services, truly developing that microsystem, multidisciplinary context. Realising the benefits of mobile technology, that's kind of happening in our organisation at the moment. And also a focus on the innovation side of things rather than the improvement side of things, despite the fact that those two go hand in hand. But developing infrastructure within the organisation to really promote innovation. And that, I think, is it. Thank you very much, and I'm happy to take questions.
Let me give a minute to anyone who's interested in asking a question to come to a microphone. Perhaps in the meantime, if you have a question, you can stand up and let me ask you, perhaps you could give a little more context of the types of reductions that were happening as you were trying to improve quality and do things like reduce the waiting times, handover times, and things like that.
So reductions in terms of the financial situation and so on. Well, every team within our organisation, well, actually we've changed it. Historically, every team has had a cost improvement target. And if you work in the NHS, I guess you are fairly familiar with that concept. And that's because we've got to demonstrate that we are becoming more efficient every year. So every year, the service has less financial resource to play with. And that's those levels used to be around kind of 2-3%. They're now at 4.7-5% of budgets. That's significant, whatever size of budget you have. And so I think that's why the traditional model of just taking that resource out through vacancy management, etc., can no longer occur. We need to kind of engage the staff in really looking at their ideas and knowledge about what can work better in order to make that kind of efficiency work and still deliver an effective and quality service.
Do we have any questions? Well, thank you, Anne.
Okay, thank you very much.
So finally, I would like to introduce Hugh Rogers, who is currently the consultant urologist and divisional director for surgery and critical care at West Middlesex Hospital in London. And previous to this, he's worked for 10 years for the NHS Institute for Innovation and Improvement, working on quality improvement.
Thank you, Kim. Yes, so it's a bit of a muddle, isn't it? I'm a urologist. I'm a divisional director, and I've been working at national level as well. It was in the 1990s when I was clinical director for services that I got really seriously into quality improvement. I joined with the NHS Modernisation Agency in about 1999, transitioned from the Modernisation Agency to the NHS Institute in 2005, and started out working with colleagues on the Productive Ward programme. So as a surgeon, of course, it was a very exciting moment when the Institute decided that there was a role for a national programme based on the operating theatre. As I said, I'm a urologist, which is why I found that when I was walking around in Boston one day, and I just thought I had to have it. So what am I going to cover? I'm going to cover what is the productive operating theatre, how did we develop it. The programme is a systematic process. Those of you who went to Lynn Marr and Mark Muggleston's session this morning will be familiar now with the work process that the Institute's adopted, and we use that work process throughout. The programme is based on a combination of improvement methods, lean thinking and human factors. And it will become obvious, I hope, why in a moment. And then there's been a national and international rollout. I hope to talk a little bit about the benefits, why it's a good thing to do. What might you learn from our experience, and close on some critical success factors. So that's my outline for the talk. Oops, I've gone the wrong way. Now, that's interesting. So, as I say, it's part of the productive series. Anne has already introduced you to the concept of the productive series, and these are some of the productive products that the Institute has developed and delivered. Productive general practice needs to be added to that. And at the outset, in common with all our works, we started with understanding and reframing. Okay, so we went out and we visited a lot of hospitals. We went out and visited other organisations that were lean-based organisations, logistics organisations. We went to Heathrow Terminal 5, which is a massive airport terminal with huge issues about demand and capacity in their security services. And we understood how to schedule from that, how to adapt to variations in demand. So from understand and reframe, we then went into pilot hospitals. So we worked with 3 hospitals to generate ideas, to test ideas, to see what worked. Most importantly, of course, to learn what didn't work and to fail early and not repeat those experiments elsewhere. And when we thought we had a package of ideas that was coming together as something that might work, we then transferred that learning to 3 more organisations to really make sure that the delivery package was effective, was working. So we were prototyping the delivery, and then we rolled it out across England from 2009 up until the present moment. At the heart of it is this. This is our triangle. You'll be familiar with a 2x2 balanced scorecard approach, but we didn't want to present it as a balanced scorecard because we felt that the patient experience and outcomes were at the heart of this. But the 3 main drivers are in the corners of the triangles. Safety and reliability of care, value and efficiency, and at the top, and there's no coincidences at the top, is team performance and staff well-being. Because increasingly, as we went through the programme, we found that was what was driving the others, having a major impact on the others if we could develop good team performance. In common with all the productive series, it's presented in the form of a house. There are 2 reasons for this. The first is that you build a house from the foundations and then you build it up. And so this implies a sequence. The other reason was really a nod to lean thinking, Toyota production system, and the lean temple. So that's the reason for the house. But I want to begin, as you do, with the foundations. It's a modular system, as in each of these building blocks within the house is represented by a book or booklet, a guide to how to do that particular element of the programme. So let's start at the bottom. The executive leader is an absolute essential prerequisite. If you do not have commitment from the executive leadership to the programme, you won't get the resources to do it, and it will never fly. So identifying the resources, pulling together an appropriate programme team. The executive leader will know who are the individuals in the organisation who might be effective in running this sort of programme. Getting a steering group established, chairing that probably, and in most organisations, we found they ran a trust board workshop. I think the language will be different in different nations, but I guess you all know what I'm talking about here, that the organisation will have a board of some sort, in our case with both executive directors and non-executive directors, who love to hear about what's going on in terms of quality improvement within these areas. And then the executive leader can monitor and support, and most importantly, can unblock critical blockages as they arise. The first major event may be the Trust Board workshop, or maybe a visioning. So I'm going to try and see if we can get a bit of interaction here. Okay? How many people here have actually worked in an operating theatre at some stage? Great! More than half, I would say. Okay, so of those who've worked in an operating theatre, I want you to just call out. We would do this obviously in a more structured way with flip charts, post-it notes, dot voting, all of that. But don't worry about the mics, just call out. What would make your perfect day in an operating theatre? Those of you who have worked in an operating theatre, what makes it a good experience? Anyone? No waiting times. So do you mean on the day within the theatre? No waiting times? Or no waiting times to get to theatre in the first place? The whole line. Okay, I love that. And that comes out all the time, delays and waiting, particularly around scheduling, patients having to wait before they... Patients coming into the hospital who are waiting to have an operation. Why did you call me in at 7:30 in the morning when you must have known that you weren't going to get my operation done till 3 o'clock or 4 o'clock in the afternoon? Why did you do that? And you get that sort of patient feedback. And on the day, starting the lists on time. That sort of delay. So yes, delays all the way down the track, and that's a recurring theme from our theatre teams. Anyone else? Teamwork, thank you. Absolutely. So what you've got in the operating theatre is several tribes. You have a tribe of anaesthetists. You have a tribe of, we call them operation department practitioners or theatre technicians, but who actually work quite closely with the anaesthetists, so they form a bit of an alliance there, but they are a separate tribe. You have a tribe of theatre nurses, of course, whose job it is to make sure the kit's there, make sure the list runs appropriately. And then you've got the tribe of surgeons. Who was it was in another session was talking about, we'll never get the surgeons on board. Unfortunately, there's a certain amount of truth in that. So, anything else in the operating theatre what wrecks your day? What makes it perfect? Team working, no delays? A consistent and regular team. Now, that's really interesting because there's a tension there between staff rotating appropriately around an operating department to acquire a variety of experience, particularly if they're going to be working out of hours, and having a surgeon with a team around him that he knows and is comfortable with. Now, there is a resolution to that. The resolution to that is at the start of every session, the team coming together and forming the team by an appropriate briefing. And what we found is that, in our theatre teams anyway, is that briefing absolutely essentially includes introduction by name, in my theatre, first name, not surname. Let's try and flatten the hierarchy. Liam Donaldson was talking about hierarchy as being a problem. This is one of the solutions to unpacking hierarchy, is to introduce by first names. So, anyone else burning to tell me something else that would make the operating theatre perfect? Sorry? Lighting and ventilation. The physical environment, yes. To be perfectly honest, this programme hasn't addressed that. We've assumed that most organisations have got what they've got in terms of physical environment. But yeah, absolutely. Anything more? Organisation. You see, you can do interaction, can't you? Right. So, absolutely, how the organisation runs, how it's organised, how the systems flow, particularly around scheduling, I would say. Okay. So, the programme leader organises that visioning workshop. We get the team together, we say what matters to you, what drives you crazy, and then we stick it all up on a big flip chart, and then we get them to dot vote that. Now, I don't know whether you can read this particular slide, but on this particular team, start and finish on time was the big issue for them, just as it is for you, sir. What else have we got? Team working. That was you, madam. Thank you. It's as if you'd seen my slide already. But these are common themes, and they come up again and again and again, and it's not very surprising. Getting breaks, safety, flow, scheduling, really up there as number 2. Equipment, having the right kit on the day, communication, which links strongly with team working, of course, patient experience, and so on. So once we've got the programme underway, the next building block has to be measurement. So it starts with knowing how we're doing. The important thing about the measurement is to have it relevant to the staff. So the staff have to be involved in deciding what the measures are going to be. So a measures workshop with key members of staff to define what measures are going to make a difference. So session start times, a big issue for all operating theatre teams, getting the thing underway in a timely way. And then once you've got a way of presenting that, putting it in a public place so that everyone can see what's going on. And this is very much a common theme, having data in a public place. Or, in fact, to be honest, in the operating theatre environment, it may not be a public place, it may be a place that's frequented by lots of staff, but not necessarily public in terms of the data, because that's where they live. The theatre environment is a rather strange environment. People don't just wander in and out, but the people who work there hardly ever go out of there. So that's where you need to do it. Then the next piece of work is around 5S. Those of you who've done anything around lean will be familiar with what I'm talking about in terms of 5S. Taking a particular workspace and transforming it by making sure that there's only the stuff there that you need in the right amount of quantity with an appropriate level of stock, and making the whole thing clean, tidy, and using visual management to know how to find stuff. So lots of photographs inside doors about how this space is supposed to look, lots of labels on drawers, which is what you see over there, that sort of thing. But I'm sure, need to explain 5S to most people in the audience. But it's been very powerful in the operating theatre. And one of the S's there is standardise. So all our organisations have, for example, taken an anaesthetic room and transformed it, and then said, right, if that's the way we really ought to have our anaesthetic room, why would we want to have them different down the corridor? We will standardise them all down the corridor, except for certain specific variations. There may be certain bits of kit that are required in a theatre where you're doing thoracic surgery. You want double lumen tubes, which you don't need in the urology theatre, you know, that sort of thing. But by and large, standardising the layout, standardising the way the drug cupboards are laid out as well. So what is the impact of that? Well, we found quite early in our programme that we were finding that there was a huge excess of stock. People were maintaining hoards of equipment just in case we ran short. So we're talking about something like £6,000 or £7,000 per theatre of overstock in storerooms, and then when you come to the prep and anaesthetic rooms, there's another £5,000 worth of overstock there. So that reaps you something of the order of £12,000 per theatre one-off payment. Now, if you've got an ordinary operating theatre suite with, let's say, 10 or a dozen operating theatres, maybe more in most organisations, we're obviously here talking about we're already into six-figure sums of money in terms of savings. That's enough to fund your programme, but that's only a one-off. You only get that once. However, the out-of-date stocks are different stuff. If you've got stuff that keeps on going out of date, that's just a drain on your finances. And we found a lot of stuff out of date. When you go and find stuff at the backs of drawers and get it all out and dig it all out and have to throw it mostly away, when it's out of date, but there's an awful lot of stuff there, and it's going out of date progressively year on year. You get your stock levels right, you stop that from happening. So I'm giving you a flying tour through the teapot house here, but the next is the team working. And this is my particular passion. My particular passion is the whole notion that human factors in the operating theatre is a major cause of problems and issues, and whenever we investigate incidents in the operating theatre, whether it be never events such as a wrong side, wrong site, or whether it's much simpler things such as a wrong drug administration, misreading, errors and so on and so forth, human factors are always a major element in terms of the root cause analysis. So part of the programme has been to go to theatre teams, take them out of their work context, and give them some teaching about human factors, how errors occur, the psychology of human error, and then how we can implement systems to reduce error. And it's not just about the checklist, but of course the checklist is on the list of things that we want to implement. We came up with this kind of wagon wheel of ideas of things, the sort of things that we want to include in our human factors training. So situation awareness, how does a group of people maintain collective situation awareness? Well, by having regular conversations, rebrief all the time, sharing awareness of what's going on. How do you deal with conflict management in the operating theatre? We do get that. How do you deal with assertiveness? We do some self-awareness tools. We use an exercise called Merrill and Reed. We tried doing a cut-down version of Myers-Briggs. It didn't work. It was too complicated. But Merrill and Reed, for a group of 100 theatre staff, proved to be really fun. We put people in corners of the room according to their preferred style, and we watched their behaviour And we asked them to respond to a number of questions about how they react. And it's remarkable the laughter that sort of exercise can produce in the room, but the insights about people they've been working with every day and not realising why they weren't getting through, and now how they might get through and communicate rather better. So that's been really exciting, and I've been leading a faculty that's delivered that sort of training in England across close to 100 organisations now. So that's that, and that's been a lot of my work. This is the checklist, but we've found our experience has been that actually the checklist is good, but it's not enough. I was talking about establishing teams at the beginning of the working day or beginning of the operating list. Even if you don't know each other very well, coming together and introducing, hello, my name is Hugh Rogers, I'm the consultant urologist, I shall be doing the operations today. What's your name, roll. Stick it all up on a whiteboard. I have a terrible memory for names, but we write them all down. And then I can turn around and I say, Mary, would you mind getting me this or that? And so there's the briefing at the beginning and then there's a debriefing at the end. Much harder to implement, much less obvious as to why people should do it, unless the issues raised in debriefing start to be resolved, so that I've raised an issue this week in debrief and it didn't happen next week, or won't happen next week. I'm getting my tenses all muddled up. Okay. And then sign out, time out, and sign in, time out, and sign out for each individual patient. So we refer to that in England as the 5-step model. Here's the sort of impact you can have in terms of using the checklist effectively. So this was an organisation, this is a hospital in Exeter, in thoracic surgery, and you can see that they identify that doing the wrong VTE prophylaxis, or more usually omitting VTE prophylaxis, was a frequent error. They picked it up repeatedly at the timeout. So rather than picking it up at timeout, they said, how do we redesign the system so that that doesn't happen? And as you can see, they did indeed. They've eliminated that as a particular issue. They now get to the timeout, they check the VTE, and nowadays it's generally correct. So patients are safer. The next big building block, and this layer of team working and scheduling, we've referred to as the enablers for the programme, because they're such important elements. So working out how a patient is scheduled. Of course, the main tool here is process mapping, working back from the destination, which is having the right patient arrive in the right place at the right time. How do you do that? How do you work back? How do you work back from there? So that's the process mapping generally done backwards. And the sort of solutions that we've had organisations come up with look like this in our organisations. It may be different for yours. It depends how you run your elective services. But 6 weeks out from the list, identify who's going to be away. And does that mean that they're not going to be doing that list? Or do they have a deputy who will be doing that list? And if they don't, then offering it within the specialty, within the directorate, saying, is someone else going to take that list up? And if not, then from 4 weeks saying, does any other specialty or directorate want to pick that list up? And then 2 weeks out, if no one's picked up that list, you close the list and you redeploy the staff. You manage your rosters accordingly. But by doing this, more and more of the actual scheduled lists are now run. So what you're seeing now is that there are very few sessions that actually go down. That has a big impact. So that here is a before-after chart showing mean 90% session utilisation. Of the sessions that you've got on the rota, 90% actually happened as operating lists. Actually, 90% sounds pretty good, doesn't it? Until you see what could be done in terms of getting it up to 98 or 99%, which is what was done by deploying this 642 weeks out review of the operating lists. The same organisation had been running extra lists to keep up with waiting lists. They'd been doing it out of hours and at weekends, at premium rate in terms of employing particularly the surgeons and anaesthetists. By stopping doing the extra lists because they were properly utilising their scheduled lists, this organisation made savings that we estimated over a year would amount to £500,000. But now we know another organisation in Bristol who through this same sort of device of maximising the use of the scheduled lists and stopping the extra waiting list initiative lists, have made a £2 million saving in a year. Time will prevent me from going through all the process modules. That's the top tier of the house, the attic, if you like. But just to give an illustration of what can be done in terms of improving start times, this organisation had a scheduled start time of 9 o'clock. In fact, in England, most theatres start at 8:30, but this organisation had 9 o'clock. And you can see that actually their mean start time was 9:15. What you can also see is that some of the data points are completely off the scale. Well, guess what? That wasn't that they actually didn't start till lunchtime. Actually, that was just data errors. They just hadn't recorded that the list had started at the right time. So as soon as the staff saw that, of course, they cleaned up the data. So the data quality improved, and you can almost see that, and then the actual start times improved. And I've managed to replicate roughly that same sort of chart now in my own organisation, having gone back as Director of Surgery. We're seeing start times now much more reliable. And part of the solution is just presenting the data. Part of it's also finding out the reason. And the theatre staff will say, well, of course I know, we always start late. Do you know why? Because the surgeon's late. It's the surgeon's fault. And then you do a proper root cause and you find actually the surgeon arrived in plenty of time, went to try and see the patients that were due for his operating list, and guess what? They weren't in the bed, they weren't undressed. It's all a bit of a mess in patient preparation. So there's another learning that you have to go through in terms of devising the process so that the patients are ready, so the surgeon can see them, so they arrive in theatre on time. And guess what? That works. So we went through a national rollout. We were supported by the Strategic Health Authorities, the arm of the government, really. It paid us to go and deliver an implementation support for about 110 trusts in England. There are 147 altogether, so most trusts in England. And it looks like this. There's an organisational readiness visit. We go and find out if they have got an executive leader who's prepared to be accountable. Have they got a programme manager who looks like they can cut the mustard? Have they started talking to their clinicians about getting involved in all of this? And then we took people off-site, we took teams off-site, trained them for 2 days, and then went back in to support, 4 days implementation support, and then had another cycle of taking them off-site, more training, revision, how are you getting on, problem solving, learning sets almost. And as well, there was this event of a one-day team working training, which we offered for up to 100 participants in each organisation we worked with. I delivered quite a lot of that training myself, but I had a faculty, as I say, of psychologists, surgeons, anaesthetists working with me to deliver that effectively. Our estimate is overall that an organisation that's got a reasonable improvement opportunity, that is to say, they haven't yet got all the answers in place, should be able to make something like a £3 million per annum saving with all the scheduling, the team working, the 5S, and that's for an average organisation, which in England is 16 operating theatres. That's average. Clearly pro rata, if you're bigger or smaller, you make less or more or less saving. We've not only delivered this to 110 trusts in England, but we have delivered master training internationally as well. So initially within the UK, Scotland, Wales, Northern Ireland, been to the Irish Republic. New Zealand was an early adopter. We were over in New Zealand a couple of years ago. Some health organisations in Australia, in Queensland and New South Wales. We've been to Qatar in the Middle East, and there are others in negotiation. So this is now becoming an international rollout as well as a national rollout. So my final slide really echoes so much of what Anne and Andrew have already said. It may be looking a bit different, but let's just sort of have a look around this, getting some pace and velocity into it, letting people see something's happening quite quickly. So choosing ideas that are going to give you some sort of delivery early on. Making staff available. That's the executive leader's role, is to empower managers to say, yes, you can actually take some staff out to do this, because the investment will reap dividends in the long term. Having a decent program leader, the leadership role that Anne emphasised earlier, measurement for improvement and having that displayed, gathering ideas from elsewhere, hospitals visiting other hospitals, hospitals getting ideas from places other than healthcare in terms of what. Having some sort of improvement model, in our case it's lean thinking, coupled with human factors, building a compelling story, and then having a governance and program management arrangements, a proper steering board and structures like that. And all of those are really important, but at the heart of it, clinician engagement and involvement. So getting your clinicians, that's to say doctors and surgeons, anaesthetists, nursing staff, all involved. The executive commitment and support, I think I've already underpinned. But the big one, the really big one, and for me this has been a real learning over the last few years, is harnessing the insights and knowledge of the frontline staff. And Andrew and Anne have both already said that in different ways, but that to me is at the heart of all of this. So thank you for listening.
I think we'll learn from Hugh's experience of interactive and ask if there's any questions. If you prefer to just stand and shout the question, you can do that as well. Do we have any? Yes.
I'm sorry, I didn't hear the first part of the question, but I think it was, broadly speaking, it was about, at the moment, it seems to be managers' role to deliver change, deliver targets. How do we empower frontline staff to be involved? Clearly, there's a learning gap there for some managers, isn't there? If you have enlightened managers who realise the power and the potential of involving frontline staff, then they will do that. The managers don't have all the answers, and the enlightened ones realise that. But I agree with you. Too often we do see a culture that's not like that. That's why I'm so strongly advocating that we should be working like that. We don't always see it. I'm not sure if that quite answers the question.
Did either of you want to add?
Yeah.
I think there's also something about trying to... Well, I guess people have to have faith in their frontline staff, and then hopefully the amount of targets that are being set will start to reduce. I think we're in a target-driven culture because there isn't necessarily that faith that the staff will drive the process forward, and hopefully we will reduce that culture over time. I think there's also something about trying to get the staff to own the target and trying to connect agendas. So, for example, in the MSK, the musculoskeletal example I was talking about, our commissioners wanted a 2-week target, but it also came from patients and staff that actually we're delivering 6 or 8 weeks now, but we could deliver 2 weeks. Why don't we look at what that could look like? And it was great that those two things were able to come together. I do recognise that doesn't always happen.
I think we...
As far as the scheduling aspect is concerned, obviously it's about making sure that you have no DNAs and that you fill all your lists. As far as running the list on the day is concerned, it's very much about seeing if you can get more cases through the existing scheduled capacity. So if you can start on time, if you can reduce your turnaround between cases, if you can reduce overruns, then you can make savings. Operating theatres are a major financial issue within any organisation, both in terms of the cost of running them, which is huge, but also the potential income by delivering the throughput of elective work. So it's a big financial drive, and you don't have to actually skew that too much the right way by getting more patients through and spending less to make very big financial savings. So some of that is estimated on increased income through existing throughput. Some of it's about reducing cost.
Sorry.
Oh, okay, we'll start over here and then come to you. Thank you.
My name's Lynn Callard, and I work with Hugh and other colleagues at the NHS Institute on the Productive Series. And I just wanted really to make a statement which answers both the last two questions. And I'd use the Bristol example that Hugh alluded to in his presentation, where there was a target set of £1.9 million for saving, and the general management, the improvement leads, and the team worked together and ended up making the savings, Hugh says, of £2.1 million. So there was a target, but the teams worked together to deliver that target, and that was an actual saving. And that was just as stated as Hugh said in his presentation.
Thank you. I do have a question. I'm from Auckland, New Zealand, and we have in our hospital been involved in the productive theatre program. But overall, I've been disappointed, particularly in the senior clinician and surgeon and anaesthetic engagement. And so the question is this scheme viable and possible without that engagement? And if it isn't, then how do we achieve it?
That's a tough one. I think you can go further and faster if you have clinician engagement. So that's part of the answer. How do you achieve it? For me, there have been two turning points that I've seen in organisations in terms of involvement of clinicians. One has been if you can actually persuade them to go to the visioning workshop, they begin to understand the issues that drive the rest of the staff crazy every day and begin to take ownership of that. So getting them involved in the visioning workshop is one thing. Getting them to see some of the data, of course, is another. Can you do it without them? Certainly I've seen organisations which have had minimal levels of clinical involvement that have still made progress, but not as fast or as far, I guess.
I would, I suppose similar. I suppose I'd start with, I don't think you should waste your time without their engagement. I think that becomes the project. I think you pick whatever the redesign theme is, whether it be productive ward or some other approach, and you put that over there, and the discussion and the question is, why are they not coming to the table? And the conversation clearly, while you may have targets in the back of your mind, the conversation's about, patient care. Surely you'd agree that a patient turning up on time is going to be operated on when you expect them to be operated on, and everything going smoothly, like you were talking about, is going to be better. So why don't you want to talk about it? Now, the conversation might not be that literal, but personally, I think that's the space that becomes the project. And if in 4 months' time you get back to where you hope to be, then jolly good. But I think you are, certainly from my context, I would think that I would be not wasting time, but certainly going to make a huge amount of effort for very little return. And I would apply that very clearly. We did some work recently around deteriorating patients in our wards. Despite our very good safety record, we have had a number of incidents where there's just been a failure to escalate. And we sat down at our first meeting, which was convened by our chief medical officer, and 2 of the 8 doctors that we'd asked were there, and the other 6 weren't. There's no point talking about the topic anymore. Let's find out what we did wrong. Did we just schedule it badly? Surely they're interested. That becomes the issue.
There's another side to that coin, of course, though, which is that sometimes, and I've seen it happen in visioning workshops particularly, sometimes you get people emerging that you had no idea were going to take on leadership roles, who then really get stuck in. And if you do get clinicians who are half inclined to become champions, then you have to grab them and nurture them, because they are the most precious commodity you have.
I'd agree.
This is very important to talk about cost reduction or cost control or increasing productivity, mainly in OR theaters, or maybe controlling wasting resources of our hospitals. But how can we do in order to control this waste or to increase productivity without affecting the quality of our care and the safety of our patients? Thank you.
Anyone would like to speak?
I don't see quality and efficiency as being contrary. I see them as being synergistic. What I certainly see in the operating theatre is if you have a team that are working well together, working efficiently, they get through more work, but actually it's also safer and the quality of work is higher, and they're much more inclined to treat their patients better as well. It all seems to me to work in the same direction, provided it's solutions driven by the staff. It's when they're imposed, as was hinted at over there, it's when they're imposed by people who don't quite understand what the problems are that you may get some contradictions there, yeah.
There was a terrific slide that Hugh presented, which was because of the poor scheduling, or perhaps less than ideal scheduling, they were able to decrease the number of lists that they required to achieve the same aim. Now, not buying those lists, whether it be 1 a week or 4 a week, is going to have a direct financial impact. So he's reduced cost, and it's had absolutely no impact on patient care, and probably improved staff satisfaction because they're less grumpy about standing around wasting time. So, of course you can go too far, but I suppose what we're talking about today is where do you find those little gems where you can get a win, on both sides, both in cost and quality.
We've had an interesting debate several times with several organisations implementing this, about whether you can actually get into the ground of whether a surgeon's performance in terms of speed of operating could be impacted, and we've absolutely drawn the line. We haven't gone there at all. We said that everything that we do is all about reducing the wasted time, the non-value-added time, if you wish, the turnaround between cases, the delayed start, all of that is fair game, but we don't push surgeons to go faster.
Well, thank you. Thank you all for your participation. We've just about run out of time, and I have to say, Hugh's last slide did an excellent job of summarizing the points. So once again, I want to thank our 3 presenters, and thank you.
The stories really give it flavor, don't they?
Thank you.